come 14th is the exam. So we have hardly another 2 weeks to go. So today, last week we saw about the anesthesia machines and the probable questions that the examiners may ask you with regard to the machine. In continuation of that, we will see some of the equipments which will be kept in the exam and then go through quickly the X-rays and ABG interpretations and all these things. And also, if time permits, I will complete the OSCE, which we left halfway through late in the last the class before 2 sessions. So let me first share my screen with you. So this is the presentation on equipments in anesthesia. The first few slides are on machines, so I will not waste time on that, which we have already seen last week. So just to recall this, these are all the way to store a cylinder. Examiners may sometimes ask you, how do you store a cylinder? It should never be allowed to lie down horizontally on the floor. It should always be vertical and it should be chained like this. And this is the ideal way of storing the compressed gas cylinders. And this is the way to transport them with a wheelbarrow like thing. And this is the liquid oxygen plant. Again, another picture where it should be stored and how it is done. And what are all the pressures? I told you it is approximately minus 183 compared to the 118 in the cylinder compressed small cylinders. Liquid oxygen is much more cooler, much more colder, minus 183. And this is the pressure. And they are heavy and require carefully designed concrete slabs for them to be held. And this is how the filling takes place. Whenever the liquid oxygen runs out and it is refilled by the tankers which come, and then the hose goes in and then the whole thing is filled up. So this filling is a very important process. No inflammable material should be near that, and people have to be taking care of that. And these are all the Schrader valves and the coupling devices, the probe, and how it is all these things in the last class. And this is the way the back bar, the various pressure gauges, the display, the Borden gauge, the APL valve, the two-stage regulator. This is called a two-stage regulator because it reduces the pressure to first 45 psi and then reduces further. And usually this sort of regulators are used in the ward, olden days ward. They used to have a B-type cylinder, which is larger than the E-type cylinder. And there they used to fit this. So it may be of historical importance. Examiners may ask you about why there are two pressure gauges in this thing. So this is what is called a two-stage regulator, which reads the pressure in both the cylinder. Both the reductions are shown here. And of course, this is about the Bodex seal and the pin in the capacity of various cylinders and the other details. This is about the label. It will be there on the cylinder neck. So that's the details. Again, this is another question I commonly ask. What are all the details you get from the label, which is attached to the cylinder's neck portion? So these are all the various pin index systems. And nowadays, the cylinders come with integrated pressure gauge. And so instead of separate pressure gauge, you can see the pressure from the cylinder itself. And this is another thing of historical importance. So this is also attached to the olden days watt type larger cylinders, and this is what is called the automatic wheel to open the cylinder. So here we have to have the key, which the different types of keys I showed you, which require to open the stem of this valve. Whereas if you have this sort of wheel, it is easy for you to hold and unscrew it and release the gas. So that is called the bull nose and hand wheel valve. This pictures They have a specific name. So this will be attached to the cylinder. This is the outlet and this goes into the cylinder. This is how the fitting will be there. And this is about the flow meter, which we saw in the last class, and all the electronic flow meter up to the modern one. I'm sorry. And, so this is the cut diagram also, and the oxygen failure device. All these things we have seen in the last class. Then vaporizers. So the examiners are fond of asking questions on vaporizers also. We had only a glimpse of what it is going there. So this is a draw over vaporizer, which in the olden days they used to call it as Epstein-McIntosh Oxford or EMO vaporizer, used mainly for ether anesthesia, utilizing atmospheric air and, if necessary, supplemental oxygen. So it can be portable, so you can take it even to the field and administer anesthesia. It was mainly designed for the battlefield. In those days, for when the World War I and II were going on, people were anesthetized in the battlefield. So at the time when you don't have an anesthesia machine, they used to give anesthesia with this, where atmospheric air will be drawn in, and this bellow will automatically pump, and the mask will be held, or anesthesia will be maintained mostly by the patient breathing spontaneously, inhaling this mixture. And this is another historical importance. Can anyone of you tell me what is the name of this apparatus the person is holding, and the bottle he is pouring? What is he pouring?
Chloroforms.
Chloroform, or even ether can be poured like that. Okay, chloroform, of course, was the oldest, and that was administered by this. What is the mask he is holding? What is it called?
Mask.
It is called the Schimmelbusch mask. And this bottle, do you know the name of this bottle? Where after chloroform they used to fill ether, and they even, as house surgeons, we were using this to anesthetize the patient, holding this mask in the labor ward or in the casualty whenever some small procedures have to be done. The house surgeon only has to administer anesthesia. So we were asked to hold the mask and then keep on pouring this liquid. This is called the Bellamy Gardner's bottle. Okay, Bellamy, Bellamy, Bellamy Gardner, Gardner, Gardner's bottle, and that is it used to have one outlet for pouring and one inlet for air to go in. So if you see the cork here, this is the tube with which the liquid will flow out, and there will be a tube for air to go in, so that the liquid can come out, and immediately it will get evaporated by the latent heat of vaporization. It doesn't require any gas flow, so the atmospheric air only acts as the carrier gas. And what type of breathing circuit is this? When you use this is called open breathing circuit. Okay, so patient breathes from the atmosphere and then breathes out into the atmosphere. So it is called open breathing circuit. So all these questions can be asked with this one single equipment, which is called the Schimmelbusch mask. Okay, and the few terms you have to understand with vaporizers are this difference between a gas and vapor. What is the difference between a gas and a vapor? Very commonly asked question.
When we increase the
Muthumani, are you there?
Yes, sir. Yes, sir.
What is the difference between a gas and a vapor? When a liquid becomes a gas, it is called a vapor. Okay, so most of the volatile anesthetic agents, like your ether, desflurane, sevoflurane, isoflurane, all these things are liquid in bottle, isn't it? But when they are used, they become like a gas. Okay, they evaporate and they become a vapor. So any gas that can be compressed into a liquid is called a vapor, whereas a gas is one which remains in the gaseous form and cannot be compressed. The example is your oxygen, which is used in normal compressed gas, is in the gaseous form. Only in the large bulk supply it becomes a liquid. But for that you require enormous pressures and other techniques to compress it. But in the common usage, the oxygen cylinder is in the gaseous form, whereas all other, even your nitrous oxide is in the liquid form, it becomes a vapor. Okay. Similarly, all volatile anesthetics are liquids which become vapor and go into the lungs to anesthetize the patient. So vapor is nothing but the gaseous form which can be compressed into a liquid is called a vapor at the critical temperature. Okay. So below the critical temperature only they will be in the vapor form, and above the critical temperature, however much you try to compress, a gas should not be going into the liquid. So that is the important temperature difference that they are very eager to ask you in the examination. And what is the definition of a boiling point?
Liquid at what temperature liquid will become into vapor, sir? Max.
Saturated vapor pressure is equal to atmospheric pressure, sir.
The vapor pressure of the liquid equals the atmospheric pressure. That is, the pressure equalization is very important. So the boiling point of a liquid is the vapor pressure of the liquid at which at temperature at which the vapor pressure becomes equal to atmospheric pressure. That is the definition of boiling point. And the formula to calculate gas concentration is saturated vapor pressure divided by ambient temperature. Okay. So this is how the sevoflurane vapor pressure is calculated. This is a common question they may ask you. What is the saturated vapor pressure of sevoflurane is 20.1 bar and the atmospheric pressure is 100.2 bars. Multiplied by 100 to make it percentage, you get 20.1%. So the splitting ratio, another important mechanism by which the vaporizers work. What is the splitting ratio?
Amount of gas going through the vaporizing chamber and bypassing.
Yeah. So all the fresh gas flow which is coming from the flow meter, all of them do not enter the vaporizing chamber to carry the vapor from the volatile anesthetic liquid that is filled in the vaporizer. Part of it will go depending upon the concentration that we keep in the dial, and the rest will go straight without entering the vaporizing chamber, and that is the part that goes into the chamber is called the carrier gas, and this carrier gas mixes with the rest of the fresh gas flow which is not carrying any vapor, and the ultimate output will be decided by the percentage of gas that is going into the vaporizing chamber and the part that is not going into the vapor. So that is called the splitting ratio. This terminology is also very important. And what do you mean by variable bypass? That is amount of gas that can go without entering the chamber. That can be adjusted. It is not a fixed amount. You can adjust it by keeping the dial setting at various levels. So it's called variable bypass. And measured flow. This is one of the mechanism which was used in the earlier machine like copper kettle, where you send a particular constant flow of fresh gas to get a vapor coming out. But this measured flow is not there nowadays. But roughly equivalent to that will be your Nagaswamy vaporizer, where the gases do not directly enter into the vaporizing chamber, but only the vapor is added to the mainstream by heating the liquid with the vaporizer, and that vaporized portion of the inhaled agent is added to the mixture. With the fresh gas flow. So there is no direct entry of the fresh gas flow from the flow meter into the vaporizing chamber in Nagaswamy vaporizer. In that way, that vaporizing the tech vaporizer is different. That is also a common question. Examiners will ask you if there is a vaporizer present in the machine. And latent heat of vaporization. What is the meaning of that word? Latent heat of vaporization.
The amount of energy calorie required to convert 1 gram of substance from liquid to gas.
Very good. Okay. So this, where does the heat come from for the liquid to get vaporized? 1 gram to convert into the vapor. Where is the heat gained by the liquid?
Electrical source, sir.
Electrical source only for desflurane. Do sevoflurane have an electrical source for making it into vapor? Most of them take it from the metal container in which they are poured in. Okay, the vaporizers are that is why made of metal, which are able to deliver this. Latent means hidden. They all have some amount of heat in them, and that heat is delivered. Okay, and there is a specific heat for each metal which will have that tendency to deliver. Then thermal conductivity. These are all the qualities of the metal out of which the vaporizers are made. So how do you classify the vapors? This is another question. They can be classified as flow over, bubble through, or both flow over and bubble through, with or without wicks, or injector type. Okay, these are all the various vaporization methods. And how is the regulation of output concentration? It is by variable bypass or measured flow. And temperature compensation, it can be automatic or supplied heat or manual thermocompensation, no temperature compensation, or electronic. So 5 methods are there. All the older Boyle's bottle, Raylene bottle, the Goldman vaporizer, which I showed you in the last class, all of them do not have temperature compensation. So the output is not constant. It will vary according to the ambient temperature. Whereas in the modern vaporizers, they are all automatically set in to deliver the accurate concentration by supply of heat, and the latest is by electronic method. And the vaporizers also can be classified as agent specific and multiple agents. Which is the most modern vaporizer which can handle multiple agents?
Aladdin cassette vaporizer, sir.
Aladdin, excellent, very good. You are very, very well versed with the latest development rather than the history. Okay. Plenum or draw upper vaporizer, and it can be inside the circuit or outside the circuit. Vaporizer inside the circuit and outside the circuit. So these are all the 6 classifications: vaporization method, regulation of concentration, temperature compensation, whether agent specific or multiple agents, or plenum or draw over, location, whether within the circuit or outside the circuit. And the features, safety advantages of the vaporizers: there is an interlocking system at the back bar, so you can use only one vaporizer at a time. There is a clear indication of the liquid level. What is that glass through which you see the level of volatile agent inside the vaporizer? What is that portion called? Many vaporizers have a transparent glass portion, and there are markings seen as full, half, or empty, like that, or various measures in milliliters also. What is that area through which you see whether the vaporizer is filled adequately or it is getting emptied? A clear glass portion. It is called the sighting glass. SIGHTING, sighting glass. Okay, you sight the level of the liquid to find out whether you need to refill it or not. And there are non-spill mechanisms. So how will it be indicated? What position you have to keep the dial if you don't want any spillover from the vaporizing chamber reservoir to come into the breathing circuit? In the dial, you will have a particular alphabet there.
T, sir. T tipping.
T, T for tilt. It is here. So allowable tilt. Okay. So that is if you keep the dial fixed in the T position, that means you cannot spill the liquid from the vaporizing chamber into the common area. And there are key filler or pore filler systems which are specific for individual agents. So you cannot fill a wrong, just like not able to fit a wrong cylinder in the machine, you cannot fill a vaporizer without its proper key or the pouring equipment. And there are increased wick capacity so that the amount of vaporization occurring will be much more faster and accurate. So these are the various types of the manufacturers vaporizers, modern vaporizers with all these the safety features that are there. You can see how the fillings are different, color coding is there, and the dial. This is the T position. This is 0. Beyond that, there will be T position also to prevent that tilting filling occurring. And this is how the evolution happened. So some hospital may have all these old vaporizers, and some examiners are fond of keeping all these old things. So at least you must be able to identify them by seeing this, even though you are not using them in a day-to-day basis. So the word temperature tech stands for temperature compensation. So that is how this word tech was introduced. So all these vaporizers are temperature compensated. Then you had Tech 1, Tech 2, Tech 3, Tech 4, up to Tech 6 we have. And then Ohio introduced their own without the name Tech. And there you can see this specificity is also written. You use it only for halothane, not for other things. This is the sighting glass. This portion is called the sighting glass, where you can see the level. And this is the filling port. And what is this hole for? Sometimes they ask you, what is this port? If this vaporizer is available still in some hospital or the center where you go, they can ask you about how you fill and what is this small port here for. This is a cap for the filling port. No. So in this machine, what you have to do is you can just unscrew it by rotating it anti-clockwise, and then you can remove the whole thing. This cap you can remove completely, and you will find the hole there. You just pour the halothane from the bottle into that, and you can see the level rising here. And once you finish filling it up to the full mark, you can screw back this cap. And if you invert this, you can see there is a small depression here. If you, and there will be a stem like thing, what you see in your anesthesia cylinder, that stem with which you open the gas to go, that's some sort of the same smell, stem will be there inside that opening. So you invert this cap and fix it that and unscrew that. This hole is for removing the gas. Supposing you want to remove this vaporizer and fix it into some other machine, or you want to keep it empty during the night or weekend when you don't want the vaporizer to be filled with the liquid and left it like that. To empty the vaporizer, you can use this same cap, inverting it and then opening the stem like thing. Then all the liquid inside the vaporizing chamber will pour out through that. You can collect it in the same bottle and then close that stem with this and then replace the cap. Okay, so that is the mechanism by which it is done. You can see it more clearly here. So this is the cap, and you can see a horizontal groove is there. So that will be used and this is the opening through which the gas will come out. And these are all again further modifications of the same thing for isoflurane and sevoflurane. These are the various methods of filling the vaporizers. So they can ask you what are all the safety features. This is pour fill. This is just you remove the cap and then directly pour from the bottle. This is called the key fill. So the key, there will be a square block like thing which you have to insert and then fill this bottle, and this cap will have to be fixed first. Then this is what is called the quick fill. You just insert it and press, and the examiners expect you to know all these things because in case the theater assistant or the theater nurse is not there, you must know in case of need how to fill all these equipments. And this is the Aladdin cassettes which you can use for various vaporizers, and this is the circuit, and this is electronically controlled, all connected to central processing unit, so it makes all the adjustments. So at least by seeing the picture or if that instrument is there, you should know how to identify that. And this is the thing I told you about, the position T for preventing the spillover during tilting. So whenever you want to remove this vaporizer from the machine, you always keep the dial in the tilt position, and then only. So this is mainly for desflurane. And nowadays the questions are asked on desflurane vaporizers features. What are all the things you will see in the front panel of the desflurane vaporizer? This is a very common question that has been asked. And how this desflurane is working mechanism is different from the other machines. So this is how the flow meter fresh gas flow is coming, and this is going directly into that, and you can see there are two resistors and all these things with variable resistance to the. So it is only the liquid which is injected into that and goes out. So you can see the gas does not directly enter the liquid chamber. Okay, only heated element. This heater vaporizes the desflurane, and that vaporized gas comes in here and then joins the fresh gas flow. And this is all about the circuit. So that is the main points. What we have seen is about the vaporizers. Then other common thing they will ask you is about the breathing circuits. And all of you know that what is this classification? A, B, C, D, E, F.
Mapleson
Mapleson.
classification.
It is called Professor Mapleson's classification. And he classified this breathing circuit in which particular, how do you mainly classify the breathing systems? Is it only Mapleson, or is there any other broad classification?
Open, closed, semi-open, semi-closed.
Semi-closed. So Mapleson classified which system into these various categories?
Semi-closed.
Semi-closed, sir.
It is for semi-closed. So be aware that Mapleson classified only the semi-closed system of breathing system into the various categories based on the location of the bag, valve location, the reservoir present or not, corrugated tubing present or not. All these things are the factors where you find out. And the common question is Mapleson A circuit examples are McGill and Lack. Okay, and what are they ideal for? Is it for spontaneous respiration or for controlled ventilation?
Spontaneous
Spontaneous.
They are best for spontaneous ventilation. Another common question: what is the difference between Lack and this Bain circuit?
Coaxial modification, sir.
What is the modification? Because both are coaxial circuits. What is the main difference between Lack
Inlet
and
and
Bain?
the inlet and the outlet, sir.
Expiratory.
The fresh gas flow inlet is in the middle in the Bain. Okay, the inner tube is the fresh gas flow inlet. Okay, delivery tube. Whereas the inner tube is the expiratory limb for Lack circuit. Okay, that is the main difference between these two. And to identify the inner tube, what is the safety mechanism present in the Bain circuit? How do you know that the inner tube is intact or not in Bain circuit?
Ethics test.
By doing the petics test.
Yeah. You can see the color. No, the inner tube is always
Transparent.
green in color.
Green
And
color.
through an outer transparent corrugated tube, you can see the inner green tube, which is the fresh gas delivery tube coming. So visual inspection itself will be able to tell you most of the times whether there is any breakage or not. Whereas Lack circuit, you can't do that because the inner tube is the expiratory tube, outer tube is the delivery tube or inspiratory limb for that. So this is an important difference that you have to know. And questions about ISTPs and Jackson Rees. What is the ISTP's role nowadays? Are you using it in any situation?
Training of the patient, mechanically ventilated patient.
It is used in some hospitals still where you want to wean the patient from mechanical ventilation without extubating the patient. So with the tube in situ, when the patient's spontaneous breath seems to be adequate, to supplement oxygen, you use the TPs for additional oxygen supplementation through endotracheal tube. Was there historically, Muthamani wanted some history also. historically where it was used as an anesthesia circuit? The
Pediatrics.
ISTPs. Pediatric, we use Jackson trees.
Earlier they were using.
Earlier, using, of course, I introduced it mainly for pediatric, but is there a role in adult anesthesia with ISTPs?
Post-tracheostomy.
Posterior fossa surgery in the sitting posture, they did not have monitors in those days. So, to reduce the resistance to breathing, and posterior craniofossa surgery was done purposely with the patient breathing spontaneously. Unlike the modern days where we paralyze and control, the breathing of the patient was the indicator whether the surgeon is going near the respiratory center or not. So they used to find out by sticking a small piece of cotton to the expiratory limb of the ISTPs, and if it is moving smoothly in a regular fashion, that means the patient respiration is normal. If it starts fluttering or becomes irregular, then the anesthetist used to inform the surgeon that you are going very close to the respiratory center, please move away. That is how they used to monitor. Okay, another historical importance, it was used for posterior fossa surgery in the sitting posture with the patient breathing spontaneously to identify any interference or damage to the main respiratory centers in posterior fossa surgeries. Okay, so that was the historical picture. And these are all the pictures, so you must be able to say how the position of the fresh gas flow, the reservoir, the expiratory valve, these three are the important components in the Mapleton's classification. And what is this circuit?
Brain circuit.
Brain
circuit.
circuit. You can see that green tube inside, okay, coming from that, and so this is the adult vein circuit. What is the normal length of this adult vein circuit?
108 centimeters.
1.8 meters or 180 centimeters. 108, not 108, 180 centimeters, 1.8 meters. Okay. What is the length of the vein circuit used in MRI suit?
540 centimeters.
5.2 meters, almost three times the normal. Okay, this is a very, very common question. So this is the fresh gas flow inlet to the machine, and this is the expiratory valve. This is the reservoir bag. Okay, so this is the what is this? Looking more similar to that. This is also
So this
green.
is flat circuit.
Pediatric vein circuit.
Yes.
Okay.
Oh, pediatric.
Also smaller distance. You can see the shorter distance. So what are the dimensions? Again, 5.4 in MRI, normal 1.6 to 1.8 with a 22 mm outer corrugated tube and a 6 mm inner green PVC tube of the same length. Okay, so the inner green PVC tube is the inspiratory limb or delivery of fresh gas flow. What are the indications for use of a pediatric vein circuit?
Control ventilations.
They are mainly during endoscopic procedure and in MRI suit. Okay, so this is where you use it for pediatrics. What is this circuit? Jackson Rees modification. Circuit also known as Mapleton F circuit. What are the advantages of that?
Used in pediatrics for both spontaneous and controlled ventilation.
Okay. What is the usage? Advantage. First and foremost advantage. Is there any valve? Valve. There is no valve at all. So what is the advantage of absence of valve?
Resistance.
No resistance or least resistance. Okay, so it's lightweight and portable, no valve, so nil resistance, ideal for spontaneous breathing in children, and can be used for both spontaneous and controlled ventilation. Minimal apparatus dead space. Okay, where is the dead space in this circuit? How will you calculate the apparatus dead space in this circuit? In other words, in any circuit, how will you calculate the apparatus dead space?
It's actually the volume of gas present inside gas.
No, that is the definition of dead space. It is the gas that is not taking part in gaseous exchange is called the dead space gas. But how do you calculate the amount of or volume of apparatus dead space in any breathing circuit? What are the points?
From the
So for
inlet
my-
to the patient, sir.
Huh?
From Maple sense up to the APL valve and Maple sense deep up to fresh gas flow.
So you don't have to say individually each and everything. The main answer you have to say if you are asked about how do you calculate the volume of apparatus dead space gas, it is the volume up to the point of entry of fresh gas flow or the location of expiratory valve. That is all the answer that you have to give. The volume of apparatus dead space ends at the level of point of entry of fresh gas flow or the location of expiratory valve. So here if you see, this is the adapter for the mask or the endotracheal tube. Okay, and the fresh gas flow is coming almost into the mask or into the endotracheal tube. Okay, so only this portion, if you use a mask, this mask is going to be the volume apparatus dead space. Or if you are going to use an endotracheal tube attached to that, that volume of endotracheal tube only is the apparatus dead space, because the fresh gas flow is almost entering here. And imagine a McGill circuit where the expiratory valve is also very close to the mask, isn't it, or the endotracheal tube. And so from beyond the expiratory valve, distal to the expiratory valve to the mask or the endotracheal tube is the dead space. Okay, so the point of entry of fresh gas flow or the location of expiratory valve, okay, that is where the apparatus dead space will end. So requires a, but that disadvantage, what are the disadvantages of this Jackson-Reed circuit?
OT pollution, sir.
It requires a high flow rate to prevent rebreathing and air dilution. So because of this particular requirement, it causes three important disadvantages. One is wastage of anesthetic gases, pollution in the theater, and it is not economical because you have to use a larger flow, and it causes drying of the respiratory tract. So post-operative, post-pulmonary complications are more. Okay. Any idea what is this?
TP,
This is very IS TPs in the older method. Okay, it was all, now everything is plastic. In the earlier days, it used to be the metal TPs. So this is a stainless steel metal with a tube for attachment to the machine to deliver the fresh gas flow. This is the patient end, and this is the expiratory limb. So the components of IOSTPs are inspiratory limb, expiratory limb, and point of delivery of fresh gas flow. So that is why it is called the TPs, because it resembles the alphabet T. There are three portions. One is inspiratory portion, expiratory portion, and point of entry of fresh gas flow. So this is the metal IOSTPs. What is this?
Reservoir
The
bag.
peculiarity of this bag that you see here. Do you find anything unusual in this bag?
Color of the bag.
Opening.
Open,
This is an open end. Actually, because of the photo you can't see there, but actually Jackson-Reed described that the reservoir bag should not have any valve at all. But nowadays we are putting a white plastic valve to adjust the filling of this bag. That should not be done. So the original description by Jackson-Reed is attachment of a half-liter reservoir bag with an open tail, so that there is no valve anywhere at all. If you put that plastic adjustable valve, then it will offer the resistance. So the purpose will be defeated. So here, people used to, when they use the Jackson-Reed's correct description bag, you have to pinch the tail, allow the bag to fill, squeeze it, and then release the tail to let out the expired gases. That was more cumbersome because you have to use your index and thumb finger for pinching it, and then other fingers for squeezing it. On the contrary, they found having a hole here is much more comfortable for doing a controlled ventilation using this bag. And this bag is known as, anybody? It's called the Kun bag, K-H-U-N, Kun Hyundai. And these are all various forms of TPs with the fresh gas flow inlet located at various situations. And they have, this is the classical ISTPs. It's a modification. This is called the Washington ISTPs, and this is called the Norman ISTPs. So all of them are TPs only, but in a little modified way. What is this?
Reservoir bag, sir.
Reservoir bag. Any idea what will be the volume of this?
250 ml, 500 ml, 2 liters.
You have half liter, 1 liter, 2 liters, and
3
three sizes.
3 liters is also
250
there.
ml, sir.
3 liters, not 250 ml.
This
have-
is really
No, the starting is 0.5 liters.
Yes.
Okay, and goes up to 3. 0.5, 1, 2. There is no 2.5, but there is a 3. Okay, so this is how. Now, the question here is, what are the functions of the reservoir bag? This is another common question in the examination. Why do you need a reservoir bag in the circuit?
To support ventilation.
Support the ventilation. That is, you can assist or control the ventilation. Okay, very good.
Visual and tactile observation of patient's spontaneous breathing, sir.
Very good. Excellent visual and tactile observation. Very
Volume
good.
buffer, sir. Volume buffer.
Volume buffer.
Volume buffer, sir.
It can prevent barotrauma by adapting itself and taking the excess gases if there is a volume increase by supposing you activate the oxygen flush suddenly. This bag can expand and hold all that gas instead of transmitting it to the patient, so it can prevent barotrauma. But what is the most important if supposing you allow the patient to breathe spontaneously in a breathing circuit? What is the role of
it provides a peak inspiratory
Peak inspiratory flow rate, sir.
inspiratory flow? Yes, that is a very important part. So you can see that is why I have given it in specific red letter. Functions, it acts as a reservoir. It provides peak inspiratory flow. So if you don't have this bag, your patient will not receive the adequate volume for peak inspiratory flow, which is much higher. And it provides a means whereby ventilation may be assisted or controlled, protects the patient from excess pressure by absorbing that excess gas, and it can help in visual and tactile observation. Now you find there is a small ring in this bag here. What is the purpose of the ring at the tail of the bag?
Hanging to.
For
You
holding,
can
sir.
hang it if you want to wash it with an antiseptic and then dry it. You can hang it. Any other purpose?
If we are holding the mask with 2 hands, we can hang it and we can observe.
Holding the mask with 2 hands.
provide attachment to the
So sometimes if you don't have a half liter bag and you have only 1 liter bag, what you can do is you can bend this into half and then put a thread around it or a rubber band around it and make it into a half liter bag. Okay, so that is the, and why these reservoir bags are always made elliptical and not circular?
elliptical provide more force, more area.
More grip, better facilitates a better grip. Okay, rather than trying to keep it circular. What is this equipment? What is the name of this equipment and what is the function of it? Where do you find this? Any idea?
It is presented
Holding reservoir bag, sir.
Found in reservoir bag. So this is the portion where the reservoir bag will be. This is the neck of the bag. Okay, this is the body. This is the tail. So this neck of the bag is made to slide over this, and then it will be kept in position. Otherwise, it will try to slip out. And this will also help to connect it to the breathing circuit or your endotracheal tube, whatever you want to do. And this strips of plastic which are going down in a conical fashion, what do they help?
Anchoring the bag.
They prevent it from rolling back. Okay, this is called the special plastic cage. On the neck of the reservoir bag, at the site of tube connection, there is a special plastic cage which prevents the upward turned. This is the upward turned bag. Okay, so it should not roll down and occlude the filling. So that is the main purpose of this. So this is called the special plastic cage. What are all these things? This has been an part of the
APL valve.
valve has been assembly has been dismantled. Okay, so you find the spring, you find the lead. So this is the points, paper, turning screw, disc, valve, and all that. So this is also called the adjustable pressure limiting valve, which has got a spring-loaded disc, commonly used in inlet or patient or exhaust port. These are all the locations where it may be situated, and it can be used both in spontaneous and controlled ventilation. So in controlled ventilation, you are supposed to keep it as much as possible closed, whereas in spontaneous ventilation, it should be kept fully open. If you keep it partially closed, it will help in producing an effect like a CPAP. And the pressure required to open is less than 1 centimeter of water. So that is another exam question that they will ask you is, what is the pressure required to lift this valve disc and allow the exhale gases to go? What is this shown here?
Laryngoscope with endotracheal tubes.
Endotracheal tube. Anything else? Is the endotracheal tube just there is a stillet. Okay, so that also you must say.
Tube along with
It
modified
says
McIntosh
tube, the stillet with a McIntosh laryngoscope. What are all the things you are seeing here? A, B, C.
A endotracheal tube, sir. B stillet. C bougie, sir.
Stillet, bougie, some elastic bougie.
Okay, very good. So disposable cup tube, stillet, and intubating bougie. What is shown here?
It's a railroad curved endotracheal tube on a bougie.
Railroad, if you first put the bougie and then you push the tube inside, it is called railroading. But already it has been introduced and kept in a particular position. Supposing you don't have any helping hand, you are doing a case in the middle of the night and you think it is going to be a difficult intubation. And if you first put the bougie, there is nobody to thread the tube for you. Then you can, as a single person, you can do. This is called ET tube loaded bougie. Okay? So what you have to do is, in such cases where you anticipate difficulty, you load the tube up to the half mark. And then after you do the scopy, you pass the bougie into the trachea and then push the tube. Okay, this is also called kiwi grip. Okay, so for a single person intubation with a bougie without a helping hand, you can do this. What is called the kiwi grip. This is a armor tube. Many of you are aware of. What is this tube? It is similar looking. Huh? The bend of the tube is made like this. It is not artificially bent like this. It's a cuff tube with a bend almost like a U.
Hockey stick.
But there is no stillet or anything. The manufacturing itself is done. What is this purpose for? In which surgery you will use it, or in which patient you can use this? This is a tube specially meant for laryngectomy. Okay, so you can make a tracheostomy hole and then introduce this so that the cuff portion goes into the trachea, and this portion will be flushed with the chest wall. It won't be projecting out. Okay, so this is called the armored laryngectomy tube. What is this tube? Many of you would have used it or seen it.
Ray tube.
Ray, cupped oral ray tube. All
Oral
you are just saying ray tube will not get you marks. You have to be very specific. It's a cupped oral ray tube. This is
North pole ray tube.
Cold ray.
Ray tube,
again
cuffed
cupped
ray.
nasal ray tube. North pole or cupped nasal ray tube. Disposable cupped nasal ray tube. So this is disposable also, not reusable. What are these?
The right side is
DLT.
right side
Double
is
dimension tube.
DLT and
Right and left.
it's actually left
Right
DLT.
and left. Very good. Right and left sided
Here
double
shape
human
is actually right.
endobronchial tube. So these are all the parts: the bronchial cuff, the tracheal cuff. Okay. So how the openings are there, all these things just for explanation. And what are all the things you see in this tube and what is it for?
Pre-couple suctioning port is there.
Excellent, excellent. High-low evac tube for continuous subglottic aspiration. Okay, this is called high-low evac tube. Mainly in ICU patient who are ventilated, the micro aspirations are supposed to be the cause for what complication?
Ventilator associated pneumonia.
Ventilator associated pneumonia, VAP. Okay, so to prevent that, this is the suction tube. So the suction tube you can see is opening just above the cuff. So all the secretions which are likely to drain down through the small gargations that will happen with the high volume cuff going down, you suck it even before they can travel down. So the suction port ends just proximal to the cuff, and you can periodically suctionate to prevent ventilator associated pneumonia. What is being shown here?
Ambu bag.
Closed suction, sir.
Ambu bag. Is it ambu bag? Just watch the pictures carefully and then answer.
So this is a it's a blockbuster LMA incubating.
LMA, incubating LMA. You can see this as this is a LMA. This picture C. These are all pictures to show how it has been introduced. Okay, this is the video scope channel. So tube has already been inserted. So intubation through LMA protector, the technique that is being done. What does this picture show? Again, you can see a tube here. You can see fiber optic
Injection through fiber optic.
Flexible bronchoscope loaded with PT tube through catheter mount. Okay, so you can continue to ventilate the patient at the same time. You can put the scope and try to intubate also. What is it being done here?
So this is
holding and
Fast LMA, sir.
a fast track LMA holding.
Is the LMA inflated or deflated?
So LMA is actually deflated deflation technique.
Various sizes of fast track intubating LMA, and that is how you deflate it before use. Now you have two
LMA.
LMA.
There's a deflator cup, dedicated deflator cup, and then introducer.
Introducer. Okay, very good. So I have rubbed out all the pointers. This is how it should proceed to supreme LMA compared, and these are all the parts of that. This is Procil, this is supreme LMA. Both have a cuff and both have bite blocks and both have a drain tube as well as a air tube. These are all common, but this has got a pilot balloon, and this is the opening for drain tube, and this is the introducer, and this is the deflator for the cup. So both of them are left. Now, this is another equipment.
High gel, sir.
High gel.
High gel, very good. What is shown here? It is the high gel supraglottic airway device. It has a what are all the components marked here? I have first 15 mm connector I have opened. What is the next one?
This is the
line
Gastric port, sir. Gastric port.
Proximal end of gastric channel. The proximal end of gastric
block, sir.
white black. Very good. Integrated
block.
white block. What is the next one?
airway tube.
Airway tube. Buccal cavity stabilizer.
Stabilizer.
Buccal cavity.
Sir.
Then epiglottic
Epiglottic rest. Very good.
Then we have a soft
inflatable cup.
and
Distal
last
end
one
of
is a
gastric
gastric
channel. So this is distal end of gastric channel. This is about proximal end.
end of the gastric channel.
The high gel. Okay. So excellent pressure ventilation and superior gastric reflux suction. Okay. This is a okay. What is this? Busca mask. Very good.
This is a Busca.
Disposable cupped endotracheal tube connected to catheter mount and syringe for inflation. Okay, so this is how sometimes they may ask you, what is this particular tube called? Any name for this?
So this is a reinforced endotracheal tube for that is LMA.
Reinforced will have the.
So reinforced means like
color itself is something different, no? From this, this is more transparent. This looks milky white or
milky white.
Silvery like that. It's called ivory tube. Okay, ivory oral cupped endotracheal tube, the 15 mm connector, catheter mount with suction port. Okay. What is this type of intubation called?
Submental intubation.
Very good, submental intubation. What is being done here? This is nasal intubation. You see the surgeon is opening the mouth and this is a tube with the connector. And what is this? This gauge. What is it used for? And this has been used here, the nose, between the ala and the endotracheal tube. So what should be the purpose of this? Looks more like a sponge, you know. Are you able to appreciate that?
To prevent the pressure source, sir.
Nasal intubation, FMT sponge. It's on FMT sponge to prevent erosion and injury to the ala. What are the parts of a Macintosh laryngoscope?
System of an
Just going to show the picture with the markings. You must identify. What is this?
Is the handle, sir?
Handle. This is
the base of the
Hook, sir. Hook.
sliding hook for the tongue blade. What is this?
Flange.
This is the
Tip or beak, sir.
Tip or beak. This is the tongue blade. Very good.
Spatula.
So this is the handle, hook on base. Then you have the vertical strip. Then you have the flange. This is the tongue spatula. This is the beak or tip. Okay. So these are all the various names. What are shown here?
Curved and straight.
Different types of curved blade and straight blade. Miller and third straight blades of laryngoscope, Macintosh Miller, various sizes. What is this?
it's a McCoy's blade.
McCoy blade. Very good. McCoy blade laryngoscope. Excellent. What is this?
This is a rigid
Rigid bronchoscope with a microlaryngeal surgery scope.
with a microlaryngeal surgery.
So because it can be supported here. Okay. So microlaryngeal rigid bronchoscope for microlaryngeal surgery. This is
This is retromolar.
This is also a rigid ventilating bronchoscope.
Rigid ventilating bronchoscope.
Okay,
Yes.
for removing foreign bodies, we can use this. This is a ventilating bronchoscope. This is the how you can connect your breathing circuit for ventilation. And what is shown here?
So this is a
Jet ventilation.
Excellent. Sanders jet ventilator. Very good. And this is another form of the same thing, which is called Manujet. Okay. So this is anybody know what is this portion called? Something like a lever which you press, you can send a jet of gas, and if you leave it, gases won't flow. Okay. Any name for that particular portion of this Manujet? Why it is called Manujet?
Manually we can.
Manually, very good. That's all. It is a part you manually operate it, so it is called manual jet, and this is called the toggle switch. TOGGLE toggle. That is when you press, it will push the gas or release the gas. When you leave it, it will won't. Okay. What are these?
oropharyngeal air.
Various sizes of disposable, color coded,
Color coded oropharyngeal air.
all these answers are expected in the exam. You cannot just say oropharyngeal airway. These are disposable, color coded, various sizes of oropharyngeal airway. Okay, so how to select the ideal size for the patient, which you should
From the
measure.
mouth to the tragus.
Not tragus, angle of the mandible. Okay, for
I see.
oropharyngeal airway, from the angle of the mouth or the middle of the mouth to the angle of mandible. But for nasal only, these are all the various sizes of nasal airway. So for nasal airway, you start from the tip of the nose or area of the nose to the tragus of the ear. Okay? So for oral, from oral cavity to mandible angle, from nasal to tragus. This is how you measure the adequate size before you insert it. What is this?
Ovasic.
Ovasapien. Ovasapien airway. What is this used for?
So for fiber optic for preloading the electrical tube.
Yes. Berman is another thing, both of which you can use for increasing your fiber optic scope without getting damaged. Okay. So FOB scopes through the airways, that is Ovasapien or Berman airway. What are these?
This is color coded
Suction
catheter.
Plastic suction catheters, which are color coded, and various sizes. You must be able to identify the colors and the sizes. What is the size written? How do you measure the size? What is the unit used for the measurement? French. What do you French gauge? What is the relationship between the standard SI system and the French gauge system? What is the
One French is equal to 3 French is actually 1 millimeter.
1/3 of the.
The French gauge number divided by 3 will give the outer diameter in the standard SI system. Okay, that is how you have to answer. The French gauge number, for example, if you choose a 18 French poly catheter, you divide that 18 by 3, the outer diameter of the tube is 6 mm.
6 mm.
Okay, that is how the equation goes. And if you choose a 12 French nasogastric tube, then 12 by 3 is 4 mm. That is a 4 mm tube. Outer diameter is 4 mm. Okay, so that is how you have to say that. And what is this?
Close.
It's also a suction catheter, but what is
Closed.
the peculiar?
Closed suction.
Closed
It's
section.
called pressure control. It's not closed suction. It is you can, by occluding this port only, you will be able to suck. So when you introduce it, especially into a tracheal tube, you should not introduce it with the suction on. So to prevent any collapse of the airway, first you lubricate and introduce the tube up to the length where you want to remove the secretion. Then occlude this pore, and then you suck out the secretion. Then again during removal, you have to take your finger off so that there is no continuous suction while removing. Otherwise, it will cause the collapse of the lung. So in order to prevent that, you can control the pressure by occluding this. So this is a suction catheter with pressure control. And these are the various sizes and color codes of that same thing. And what is this?
This is a plastic photo
Yanker
suction.
suction canvas.
Anchors.
Yanker plastic
This
suction
plastic
tip with a
suction.
tube. Okay, so this is the angulated thing. It may come in plastic. In some hospital, it may be in metal, reusable metal also. So it is called the Yanker's tube. And what is this?
Closed
Somebody
suction.
used- this is the closed suction, which many of you would have used it during the COVID times to prevent exposure to the aerosol. Okay, so closed suction catheter. Right. What are these?
It's color coded.
Color coded.
Different size.
Rebreathe.
Inflatable.
Facial distance.
Color
Breathable.
coded.
Visible
Not
mask.
breathing mask.
Transparent.
Transparent.
Inflatable. Various sizes of disposable mask. Okay, these are all also scented. These are all scented. If I don't know how many of you have smelled to these masks, when they come in fresh packing, they will have a very pleasant fragrance. So they are scented, color coded. This is the port through which you can inflate to adjust to the fitting, and they are transparent. Why they are transparent? The earlier masks were all dark black.
Secretions
You
can
can
be
see
seen.
when the
Visible
patient
secretions.
vomits or if there are a lot of secretions while you are ventilating, you can see through that. Okay, so that is the inflatable, transparent, disposable, color-coded mask with various sizes. This is the old-time mask called the anatomical mask. Huh? What is this material out of which this is made up of? You have some answer here also. Are you able to read this?
Anti-static.
Anti-static rubber.
Rubber band.
Okay, this is the anti-static rubber out of which it is made up of. And what are these things for? A metal with small projections, 5 projections are there. What is this for?
For hand grip, sir.
Huh?
Hand
Hooks
grip.
to fix them.
Stabilization of the.
So hooks to fix the mask after.
It is called the harness hook. It is called the harness. 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 All of you would have seen those who have traveled in jet cars. You see there is a band holding to the eyes of the horse. Okay, like that you can fix the whole mask. In those days, they used to do all surgeries and spontaneous respiration. So the anesthetists used to get tired holding the mask. So they used to use a apparatus. I am going to show you a little later where you can sit behind the occiput of the patient. The 5 straps will come and you can hook this onto that so that the mask will stay fixed to the patient and anesthetist can be free to do other jobs. And what is this mask called?
Brendel
Baker Susek mask. Very good. What is this mask for?
This is for
endoscopic transparent face mask for scopy. Okay, so you can connect this breathing circuit here and surgeon can open and put his scope through that and do the scopy while you are holding the mask. Okay, and this is the harness, what I told you, how you fix it for that. This is the occipital portion. So it will be here. I mean, sorry, this is not for this. This is for somebody else who can use this on a regular basis. What is this mask for?
NFP.
This is for CPAP mask. Okay, this goes to the forehead, and this goes to the forehead. This is the occipital portion. This goes to the facial hook. So while sleeping in the night, patients using CPAP mask, they will have to use this. The tube will come get attached here. And this is the harness. As I told you, this portion will be kept on the occipital level, and these straps will be hooked onto this. You can tie it here and slide it into that. Okay, so this is the harness to hold the mask in position. What is this?
Venturi mask.
Venturi mask, adjustable Venturi
Adjustable
mask.
Venturi mask, color coded.
Okay. What are all the equipments that you see in these two lines?
This is the self
Top line
inflating
and bottom line.
Ambu bag with
Bag
face
valve
mask,
mask.
sir.
bag one mask.
Ambu valve mask or bag valve mask. This is again the one I showed in the earlier picture. This is the CPAP mask.
This is
This
nasal
is
cannula.
Nasal cannula.
Nasal
nasal
cannula.
prongs or nasal
Prong
cannula.
nasal.
What is this?
Non-rebreathing.
We have non-breathing mask.
Breathing mask.
With the,
This is
this is
Oxygen.
hyperbaric.
hyperbaric chamber.
Hyperbaric.
And this
This
is
is face mask.
Face mask.
simple
Simple
Hudson's mask. Okay, so this is ambu bag, CPAP mask, and nasal prongs on the top line. And FM with reservoir, that is face mask with reservoir, hyperbaric chamber, and Hudson's mask without reservoir. What is this equipment?
HFNC, sir.
HFNS, high-flow nasal
Very
oxygen.
good. High flow nasal oxygen machine. What is this?
This is the
Portable oxygen.
oxygen
Portable
concentrator.
oxygen concentrator. Very good. Very good.
Concentrator.
What is this?
Non-rebreathing.
Complete non-rebreathing.
Non-rebreathing mask.
Partial.
Yeah, non-rebreathing mask. What are these?
This is Quinky needle.
Plug
small
product,
catheter,
final needles.
Quinky needles.
Okay, but
Ivory.
these are the various tips like Kinky, Whitaker, Prof, and
Greens.
Green. Okay, so these are the various. Out of which Sprott and Whitaker have side holes with a closed
Pencil
tip.
pin.
Okay, all other things are all with a hole at the tip. So Kinky, Whitaker, Sprott, and Green. What is this?
This is epidural.
Combined spinal
Combined
epidural.
Spinal epidural. CSC set. Very good. What is this?
Two eyes epidural needles.
It's epidural needle.
Epidural
Tuhi
needle.
Tuhi needles.
What is this?
This is
Elastomeric pump.
Very good. Elastomeric infusion pump. Excellent. Very good. What is this equipment?
Nerve stimulators.
Referral nerve stimulator.
Is it a nerve stimulator or something else? The current stone is only 5 milliamperes. And you have only two.
Sir, locator, sir. Nerve locator.
This is a nerve locator, peripheral nerve stimulator for nerve block. Okay, it is going to be ideally called as nerve locator. So what is chronoxy and what is Rio base? When you use this nerve locator, this question may be asked. What is chronoxy and what is Rio base? Okay, find out and tell me. What is this instrument? What is in here?
Acceleromyography.
Sir.
Kinomyography.
Acceleromyography.
CNS for
This is
monitoring
for-
neuromuscular junction, peripheral nerve stimulator for monitoring. And how is it different from the one shown on the left? Can see the strength of the current delivered from this.
Tetralogy of Fallot. Yes.
Minimum. What is the minimum current in this monitor used for neuromuscular junction function?
60,
Supramaximal stimulus is formed.
Supramaximal stimulus is
50
5
milliamperes.
It starts from 10 milliamperes. Whereas
10 milliamperes,
this
25.
nerve locator is less than 5. Starts from
5.
0.1 milliamperes up to
1
maximum 5 milliamperes. Whereas here it starts from 10, 20, 30, 40 like that. It jumps in tens. It is not in decimals. Okay. And what is this?
So this is
Very
Where is it used? You can see all the
neuromuscular.
neuromuscular.
neuromuscular monitoring of what functions or what stimulations?
Neuromuscular.
Which
Brain of
stimulation? Brain of
Yes.
four, tetanus, and
Brain of four, tetanus. Double
DBS.
burst.
What is this thing?
Single
What
touch.
mode of stimulation?
Double burst.
Double burst is
Double
here.
burst.
PBS is here. What is missing? What mode of stimulation is missing?
Post-sedentary contraction.
PTC is missing. Post tetanus count is missing. Okay. Can you use the above nerve for nerve block?
No, sir.
No, you cannot, because the minimum current is 10 and it will be
Current.
very, very painful. And it can stimulate the muscles also, giving a false impression that you are near the nerve. Okay, that is the answer you have to give. Whether you can use the stimulator which is used for neuromuscular junction function monitoring, can it be used for nerve location? You cannot, because the minimum strength is 10 milliamperes. And even if you use that 10 milliamperes in a conscious patient, it's quite painful, and it will stimulate the muscles, adjacent muscles also, giving a false impression that you are close to the nerve. And what is this? Can you see something like a cylindrical bulb here? Something like a Goligundu
Yes.
marbles which you play with. This is called the ball electrodes. This is called the ball electrode. And what is this which you are seeing here?
And
Red
so
is
It's
a
called
positive
the
and the
alligator or crocodile clamps. Okay,
Crocodile.
so when you want to do a single use for this stimulation, you can use this directly with the ball electrode. But when you have this crocodile clamps, how will you use this?
you have to place a ECG electrode.
Excellent. You place two ECG electrodes over the nerve, proximal and distal. Which one goes to proximal? Which one goes to distal?
Black goes
to distal and red.
goes to proximal.
Very good. Excellent. What is shown here and what are all the displays you see here?
So as a
It's
maximum
oximeter.
Mobile
pulse
oximeter.
oximeter
Post
modification.
pulse oximeter.
Oxygen saturation with pulse rate with hot waveform
Hmm.
perfusion index, sir.
Hmm.
And the battery percentage.
Respiratory
Okay.
rate.
Respiratory rate.
Bluetooth
So
mode.
this is a finger probe pulse oximeter. Displays SPO oxygen saturation, pulse rate, plethysmograph tracing, battery charge indicator, a Bluetooth connector. This symbol is the Bluetooth connector symbol. All of you would have seen in your phone also. And then respiratory rate from plethysmograph and pleth variability index and perfusion index. All these things are given. What is pleth variability index, PVI, used for?
The maximum amplitude divided by minus
It helps to assess the strength of the peripheral circulation.
circulation.
Okay. And what is Massimo?
Massimo introduced the modification that is actually the can
Very good.
differentiate the other thoughts, the functional saturation
Yeah.
oxygenation.
It is the name of the American company making non-invasive monitoring equipment. They use a technology called signal extraction technology, or set to remove the artifacts and motion-induced changes to give the accurate reading. Okay, so Massimo is not a technique; it is the name of the company. Okay, so this what is shown here is something which I read this morning preparing for the class. Just go through all the things that are given here and try to say what could it be. Starting from A, there is an intravenous fluid bag, volume drip chamber, intravenous tubing, inspect for air bubbles, intravenous cannula, check for any disconnection.
Checklist, sir.
Check, airway device, checklist, or Eurobag, suction drains. This is called a closed loop monitoring. Okay, so in closed loop, where all you use closed loop nowadays?
Closed loop anesthesia delivery system.
Delivery equipment,
Lab.
ventilators, okay, and then PCI pumps, PY equipments, because you get the feedback from the patient's parameters and then automatically the machine will adjust. That is the purpose of what is called the closed loop machines, whether it is a monitor or whether it is a equipment delivering drugs or ventilation, whatever it is, the closed loop technology helps to get the feedback from the patient parameters and adjust automatically without our need for interfering and doing every time. Okay. So what is closed loop monitoring? How can it be defined? This is the answer. Closed loop monitoring is a method to ensure comprehensive monitoring of the patient at regular intervals. And how is this achieved? It is achieved by monitoring closed loop visual inspection of the patient, anesthesia machine, standard monitor, and surgical field at regular intervals in a predetermined sequence so that none of the parameters are missed. So all these days, if you have a multi-parameter monitor, we used to be quite relaxed, saying that it will show any problem with the patient, immediately a visual or a auditory alarm will go. But now the concept is changing, that you have to have not only the monitor visible to you and watch it, but you should also periodically see the patient's anesthesia machine functioning, as well as the surgical field to see the color, the relaxation of the muscles are tight. Even before the surgeon tells you that he doesn't have adequate relaxation, you must be able to judge and say whether the relaxation is sufficient for him or not. And the main sequence is as follows. You first start with the patient doing the clinical assessment of pulse, airway, chest movement, intravenous lines, rate, and amount of infusion, urine output, surgical field, blood loss, suction drains, etc. Then look at your monitor. Then look at your anesthesia workstation for vaporizers, ventilators, then operating table and patient record, and again back to the patient. So this becomes a complete loop. This is how the whole thing is achieved. Okay. So this is what I wanted to show you with regard to anesthesia equipment. Now we'll go to the ASCII, which we left in the last class halfway through, which will also contain some questions on the X-rays, blood gas, and other things. So in the form of ASCII, it is better rather than trying to tell you each and everything. So body plethysmography, where is it used?
It's a measurement of FRC.
To find the
Functional
flexible capacity.
Very good. Excellent. Okay. And it works on which law?
Boils
These are
law.
the law. It works on Boyle's law. Says that a constant temperature, the product of pressure and volume is constant. So this principle can be applied to the measurement of lung volumes. A change in plethysmographic pressure will reflect the change in lung volume. So this technique is most frequently used to measure the FRC, functional residual capacity. Now frost develops on the outside of a nitrous oxide compressed gas cylinder during general anesthesia. This phenomena indicates
Joule-Thomson effect.
saturated vapor pressure of Joule-Thomson effect. But the choices are given here. Saturated vapor pressure of nitrous oxide within the cylinder is rapidly increasing. The cylinder is almost empty. There is a rapid transfer of heat to the cylinder. The flow of nitrous oxide from the cylinder into the anesthesia machine is rapid. None of the above. Which is the answer?
Flow.
Rapid
D.
transfer of
D is the answer. The flow of nitrous oxide into a machine is rapid. Then only there is a drop in temperature, and we discussed it in the machine class. Okay, Joule-Thomson effect. What you said is right. And where balanced anesthetic is administered to an otherwise healthy 38-year-old patient undergoing repair of right inguinal hernia. During mechanical ventilation, the anesthesiologist notices that the scavenging reservoir bag is distended during inspiration. The most likely cause of this is A, an incompetent pressure relief valve in the mechanical ventilator, an incompetent pressure relief valve in the patient breathing circuit, an incompetent inspiratory unidirectional valve in the patient breathing circuit, an incompetent expiratory unidirectional valve in the patient breathing circuit, or none of the above. The scavenging reserve bag is supposed to distance.
Option D, sir.
D, sir.
An
Expiratory
incompetent
indirect.
expiratory.
Expiratory.
Incompetent pressure relief valve with the mechanical ventilator. Actually, the bag is supposed to collapse during inspiration and expand during expiration. Then only it indicates that the gases are going out, isn't it? So, in incompetent pressure relief valve in the mechanical ventilator will allow the gas to de-inflate. Now you see a name here, line isolation monitor. Where is it used?
It
It is one of the electrical questions in the OT that can be sometimes asked. This is a line insulation isolation monitor. What is its purpose? Answer is prevents microshock, prevents macroshock, provides electrical isolation in the operating room, sounds an alarm when grounding occurs in the operating room, provides a safe electrical ground. What is its function? Look at this picture and tell me. Answer can be found.
Option A.
Option
A
D, sir.
prevents microshock. Option D. You can see a
Yes.
mute button here. Can you
Mute
see
button.
a button called mute and there is a volume
Alarm.
signal. Okay, and there is a test. Okay, so the sounds an alarm when there is a break or the grounding is leakage of current is occurring. So it doesn't prevent microshock, it doesn't prevent macroshock. It only gives a warning that the electrical thing grounding is happening. Okay. Now, which finding is present on this image of this X-ray chest? What finding you see?
Left-sided pleural effusion.
Left-sided pleural effusion. Excellent. Is it how do you say
Arbitration of the costophrenic angles. Arbitration of the costophrenic angle.
Okay, it's a normal X-ray. It's a sail sign. It's a meniscus sign. It's a pneumothorax, or it's a air bronchogram.
Sail.
You said there is a meniscus. There is a fluid.
Meniscus.
This is called a meniscus sign. Okay. So when there is something like a fluid, it's called a meniscus. What is the quantity of fluid required to obliterate a cardiophrenic angle? How much of
More than
fluid
200
have?
ml.
More than 200. Minimum 200. Okay, minimum 200 for a PA view, but 50 ml can be made out in lateral view also. What is Light's criteria? Ever heard of that word?
No, sir.
Okay.
So except for pleural effusion,
Any of the following characters is classified an exudate. See, the pleural effusion can be exudate or transudate. So an effusion can be an exudate or a transudate. To distinguish between the two, if you want to call it as an exudate, the pleural to serum ratio, this should be more than 0.5 of protein, and pleural to serum LDH ratio more than 0.6, or pleural LDH more than 2/3 of the upper limit of the normal for the patient serum. So if any of these things are present, it is to be called only as exudate and not as a transudate. Which finding is present in this close-up chest X-ray image?
Lower lobe atelectasis.
Lower lobe atelectasis.
No.
There is a
Honeycombing. Honeycombing
bronchiectasis. Bronchiectasis. There is a fast.
Bronchiectasis, septal lines, accessory fissures, lung fibrosis, normal X-ray chest. These are the options.
Bronchiectasis.
Bronchiectasis. That will be too dilated bronchi will be seen. Lot of saccular and fusiform. So this is curly B lines.
Curly
Okay. What are other curly lines which are described and what is their significance?
Curly A lines.
Curly A, curly B, and curly C also is there. Where do you
Just a
find
cardiac failure.
curly lines
Behind
are
curly
A, B, and C. Okay, now tell me where is curly A seen, where is curly B seen, and where is curly C seen?
Congestive cardiac failure, curly B lines.
Curly A lines are linear opacities extending from the periphery towards the hilum, and there is a distinction of anatomic channels between peripheral and central lymphatics. Curly A lines mainly are dilated lymphatics running from the periphery towards the hilum. And curly B lines are small horizontal peripheral straight lines demonstrated at the lung bases that represent thickened interlobular septa, and they represent edema of the interlobular septa, and they are usually due to LVF, left ventricular failure. Curly B lines are usually, and curly C lines are rectangular opacities in the lung base and representing curly B line end on. Okay? So this is how these three things are seen. You can see this is curly A, usually in the top, long linear lines. Okay.
Okay, sir.
And this black is this curly white is the B. So A lines are arrow, white long arrows. Curly beams are white arrow heads. So curly B lines are these white arrowheads, and curly C are black arrows. So curly B and C are interrelated to each other. So this is another view of curly B line is curly C line. Okay, so that is how you have to identify. Which statement is correct of the following? The X-ray is of poor quality and should be repeated. The endotracheal tube should be advanced. The internal jugular catheter should be removed. The nasogastric tube should be removed. The lungs are normal.
Nasogastric tube.
Nasogastric tube should be removed.
Excellent. Why? Why do you say it is nasogastric tube to be removed?
So it is
Entered into the right lower lobe.
towards the
It is going into the lung. It should actually come into the stomach on the left side.
stomach.
So it is not going into the right side. Very good. So the nasogastric tube should be removed. Mention few complications of nasogastric tube insertion.
Bleeding, sir.
Patient
Nasal
bleed. Nasal bleed.
complication.
Next stage to plaque.
Increase the risk of aspiration, sir.
So it can be patient's discomfort. Many times, patients don't like to have this tube in the nose. And sinus infection, nose bleeds, sore throat, pressure ulcers, irritation to stomach lining, tube becoming entangled or dislodged, electrolyte imbalance such as hypokalemia because of constant drainage. What are the types of nasogastric tubes? Are there different types of nasogastric tubes? Have you heard of any names?
Riles tube.
Riles tube is a person. Levin catheter, which is a single lumen small bore nasogastric tube. Salem sump catheter, which is a large bore nasogastric tube with double lumen. And Dobhoff tube, which is a small bore NG tube with a weight at the end intended to pull it by gravity during insertion. Okay, so Levin catheter, which is commonly used. Then there's a Salem sump catheter with a double lumen. And there is a Dobhoff. This is a very old method. They thought that by putting a small metal balls in the tip of the catheter, it will drag down, go easily when you insert by gravity. So these are the three pictures. This is Salem sump tube. You see it's a double lumen, and this is the Dobhoff. This is the weighted tip, and this is the standard right. Which physical examination sign do you expect to be present at the time of taking this X-ray? So first see the X-ray and then find out or tell the physical examination sound. The answers are left-sided bronchial breathing, tracheal deviation, right-sided chest hyperresonant percussion, normal examination findings, finger clubbing.
Right
Right
side,
side
just
chest
hyperresonant.
and the finger clubbing.
This is obviously a case of
Right,
COPD.
right pneumothorax.
pneumothorax, right? Pneumothorax. You can see the homogeneous black color with no lung markings at all. Okay, so you have to find you have to expect a hyperresonant sound on the percussion. So it's a right-sided chest hyperresonant on percussion. How is pneumothorax classified?
Spontaneous pneumothorax, tension pneumothorax, and
Very good. Spontaneous or
Hydropneumonia.
traumatic, not tension. It's called traumatic or atraumatic. And two types, subtypes of atraumatic are primary and secondary. This is how it is classified. So two types are traumatic and atraumatic. And the atraumatic variety is again primary and secondary. And it can also be classified in another way as simple tension or open pneumothorax. Okay, so there are two types of classification. And how to treat pneumothorax?
Placement of intercostal chest tube.
Intercostal drainage is ultimate. But in emergency, supposing
Needle.
this
pneumothorax.
Intercostal space.
patients with symptoms of hemodynamic instability, needle decompression is the treatment of pneumothorax performed with a 14 to 16 gauge, 4.5 centimeter length angiocatheter, just superior to the rib in the second intercostal space in the mid-clavicular line. This is the anatomical location. Very often they will ask you, before you think of putting an intercostal drainage, what is the emergency treatment of a tension pneumothorax? This is the needle compression. This is the answer you have to give with a 14 to 16 gauge angiocath. That is not your just any metal needle because it will damage the lung. So you put a soft catheter into that space and then drain it. For stable pneumothorax, so this is the emergency treatment when there is hemodynamic instability as an acute complication. But in patients who developed, for example, a long-standing tuberculous patient may develop a spontaneous pneumothorax. It may not be so acute with hemodynamic instability and all complications. So that is called a stable pneumothorax. The treatment is thoracostomy tube, and it is placed in the above the rib in the fifth intercostal space anterior to the mid-axillary line, and that area is called what triangle? Triangle of safety. What are the borders of triangle of safety? Pectoral border of pectoralis major, lateral border of latissimus dorsi,
and space found by the
superior to the nipple level.
Fifth intercostal space, fifth rib. Okay, so fifth rib. Fifth rib, lateral border of pectoralis major, lateral border of latissimus dorsi, axilla above and below is the fifth rib upper border. What is the most likely cause of chest pain in this close-up chest X-ray image? Infection, cancer, trauma, fibrosis, or sarcoidosis?
Trauma.
Yeah. What do you see here? This is a fracture rib. Excellent. So it is a trauma. What is flail chest?
paradoxical movement of
One at a time. One at a time.
paroxysmal movement of chest with respiration.
Two or more segments of a same rib or subsequent ribs broken and creating a paradoxical movement.
At one place or multiple places? More than one place. You said two or more ribs, but should they be broken in one place or in flail chest is a traumatic condition of the thorax. Okay, it may occur when 3 or more ribs are broken at 2 places. So here you find there is only one broken piece. But supposing there is a break here and there is a break here in the same rib. Okay, so the same three ribs, all of them are broken in two places, then that segment alone will not coordinate with the other movement, and that will move independently, and that is called the flail chest. So three or more ribs should be broken, and they should be broken in two places so that they are not synchronously moving with the expansion of the other ribs. So flail chest occurs when these injuries cause a segment of the chest wall to move independently of the rest of the chest wall. So how is flail chest treated?
The pain relief with
Huh? You have
With
to
some
stabilize
analgesic,
the rib, isn't it?
I
Because
know.
it is broken in two places and moving independently, it has to be stabilized. So how can you do the stabilization? I think Dr. Kamachi had a similar case some time back, and the surgeon wanted to fix it. The management of flail chest should include 1. Maintaining adequate ventilation, 2. Fluid management, 3. Pain management, and 4. Management of unstable chest wall. These are the 4 things that you have to answer for flail chest. Management of adequate ventilation, because this is haphazardly moving. It will not allow proper expansion of the lung. So you have to maintain adequate ventilation. These patients may be dehydrated. When fluid overload may cause more damage here. So you have to be very careful with fluid resuscitation. And they will be in severe pain, and they will make it hold their breath, and the inadequate ventilation can happen because of pain. And this chest wall should be fixed as early as possible. So what is MIPO treatment for rib fracture?
Consider post.
Huh? MIPO. What is the expansion? This is an acronym. Heard of this?
minimally invasive.
Minimally invasive plate osteosynthesis. Okay, very good. This is called minimally invasive plate osteosynthesis. And the application of MIPO helps to operate with a small incision, reducing tissue damage. So this is how it is done. So they make a small incision over the rib which is fractured, then elevate the skin, and then put plates and twist it with the screws like this. Okay, so this is called MIPO. I am showing 2 pictures. Shown here are the plain X-ray abdomen and USG abdomen of a 6-month-old male infant with history of intermittent crying and folding of limbs, refusing feeds, mild distension of abdomen. Mother noticed a lump in the abdomen whenever the child cries. What is the possible cause?
Hypertrophic
Pyloric
pyloric obstruction.
Pyloric obstruction means the patient will be having severe vomiting. Is there
Volvular, sir.
vomiting mistake given?
Intersusception, target
Volvular.
site.
Intussusception. You can see here this.
Target site.
That's why the USG image is also given. Here it shows only distended bowel because of some obstruction. Whereas here you can see the target lesion transverse and pan-axis. Okay, so this is a case of probably intussusception. How is this condition managed? A 6-month-old baby, how will you manage an intussusception? Treated with barium, water-soluble or air contrast enema or carbon dioxide insufflations, which confirms the diagnosis and successfully reduces. So the enema itself will push the bowel which has telescoped. Usually at which location it will happen intussusception?
The telescoping of the
No, telescoping is there, but which level of the bowel it usually happens?
Ilium, sir.
Ilium.
Ileocecal junction. It commonly occurs in the ileocecal junction. Okay. So the cases cannot be reduced non-surgically, require reduction by open or laparoscopic surgery. Okay. So this first treatment is conservative treatment without surgery by giving a barium enema or a water soluble or air contrast enema, carbon dioxide insufflation. All these things are conservative methods done through the rectal route. Whereas if doesn't, but patients in shock or hemodynamic instability with severe signs of obstruction, distension, and delayed arrival in the hospital, you should not do this barium treatment. And there it should be only surgical treatment by either open method or laparoscopy. How to provide anesthesia for surgical repair of this condition? How do you manage a 6-month-old baby for laparotomy either by open method or laparoscopy and reduction, and if necessary resection and anastomosis if the bowel is
So,
not
preoperatively, we have to correct the metabolic electrolyte
Yeah, but
abnormalities,
fluid and
perform
electrolyte
rapid
correction.
induction.
So this is a quasi-emergency since long delay can result in bowel gangrene and peritonitis. So the challenges are pediatric anesthesia, fluid balance, problems inherent to open and lap procedures. Okay, this is how you have to answer this question. And which can be done with GA with caudal or lumbar epidural will be ideal. Because it's a 6-month-old baby, you can't do it exclusively under regional technique. So GA with caudal or lumbar epidural will be ideal for this. Okay. When setting an adult ventilator for pediatric patient in pressure control mode, which of the following would be inappropriate? The setting of I ratio at 1:2, pop-off limit to 30 centimeters of water, tidal volume to a minimum of 200 ml per kg per minute. All of the above are correct.
ratio.
All of the above.
All of them are correct.
Tidal volume.
C, sir.
200
Tidal
ml
volume.
per kg. 200 ml per kg.
Normally, do you give 200 ml per kg means much ml per kg for one respiration? Normally, we set it at ml per kg, isn't it?
6 to 8 ml per kg, sir.
The answer, the pop-off valve limit is the maximum pressure at which the ventilator will release excess pressure. In pediatric patient, the pop-off limit should be set lower to prevent barotrauma and ensure the safety of the patient. So the correct answer is B. Okay. Pop-off valve should be kept only at 20 centimeters of water, not 40 centimeters of water. An appropriate
50 ml.
hourly maintenance
sir.
fluid rate, child weighing 15 kg.
60, sir.
50
50
ml.
ml.
50, 25. What is the answer?
60.
50 ml.
Solid
50 ml.
B.
Yeah. So using 4-2-1 formula, 10 into 440, 5 into 210. So 50 ml is the correct answer. Okay. What about an appropriate dose of pre-op midazolam for a 6-year-old child weighing 24 kg? The choices are 24 milligram IV, 6 milligram per oral, 12 milligram per oral, 48 milligram per oral.
12 milligram per hour.
Excellent. Dose of midazolam is 0.5 mg per kg. So for 24 kg, it is 12 milligram per oral. Correct answer. A 6-year-old 20 kg girl develops pulseless ventricular tachycardia after induction of anesthesia. The anesthesiologist intubates the child, administers 100% oxygen, and starts chest compression. What is the energy level for initial shock? The options are 20,
40 joules.
40 joules.
Joules, sir.
80 joules.
20 kg. So it is 2. The recommended level is 2 joules per kg. So it is 40 joules. Correct. What
Fixed
pattern is suggested by the
Fixed
following
obstruction.
flow volume group?
Fixed obstruction.
Fixed
Airway
obstruction.
sir.
Fixed obstruction where? Extrathoracic or intrathoracic?
Extra.
Upper airway.
Fixed upper airway obstruction.
Upper airway.
Very good. How is it identified?
Both
How do you
inspiratory and
say it is?
expiratory.
Both inspiratory and flattening of inspiratory and expiratory limbs. Very good. What clinical condition causes this?
CLR.
Foreign
Gel.
foreign body obstruction.
Thyroid.
Thyroid goiter, sir.
Cyst or
Thyroid
goiter. Okay, tracheal post intubation tracheal stenosis or goiter, long-standing goiter. Okay, what is this?
Obstructive lung disease.
Obstructive lung disease, sir.
Obstructive lung.
Obstructive lung disease.
COPD.
Variable intrathoracic
But
obstruction. You can see in obstructive lung disease, it should be more scooped out. Completely, it should become like this. Okay, here it is only partially this thing. Then it becomes normal. So contrary to the first look, it always looks like obstructive, but in obstructive, it should come like this, full curve. It is called the scooped out or caved out appearance. So this is a variable intrathoracic obstruction. How is it identified? It is identified diminished expiratory limb with impairment of inspiration. Okay? So the inspiration is normal, only the expiration is actually diminished. What clinical condition causes this?
Retrosternal goiter, sir. Intrathoracic tracheomalacia, bronchial tumor, and bronchogenic cystis.
Very good. Tracheomalacia is the most common cause. Okay. Now, interpret the graph shown and what do the arrows point to?
this is obstructive feature.
This is obstructive. How do you say it is obstructive?
The scalloping of the expiratory limb.
Scalloping of the expiratory limb.
Okay, that is in flow volume graph. What about volume time graph?
So FEV1 will be decreased, FVC will be both decreased.
FVC is also decreased. Okay,
Decrease,
so this is the catch point. FEV1 also is decreased and FVC also is decreased, and this is the total scalloping. Very good. So flow volume loop on the left is normal, and flow volume loop on the right is that of a mixed disorder. Here, one more point you have missed is it's a mixed obstructive and restrictive because it has not reached the baseline. If it is pure obstructive, it should come like this and touch up to this. The entire volume should be delivered. Whereas if it is restrictive, then what happened? It is stopped short before the, here you can see it has reached up to the expiration, has reached up to the starting point, to the residual volume. Here it has not reached, it has started off with the expiration below the, even before it reaches the RV, that is residual volume. So this point you should not miss. Okay.
Yes.
So this arrow is pointing to, the upper arrow indicates the scooped appearance seen in obstructive lung disease. The lower arrow shows reduced volume seen in restrictive lung disease. So you should always carefully watch before committing as a pure obstructive whether it is reaching the full volume to the end. Then only you can say it is purely obstructive. So this is a mixed thing. So mention a few causes of mixed disorder. This is another picture to show how it is showing the low FVC, full post volume capacity. Okay. What are the few causes of mixed disorder? There you will have both obstructive and
Obesity,
restrictive.
sir.
Very good. Can be seen in COPD who have developed interstitial lung disease like SLE, ILE, IPF. It can be seen in long-standing asthma cases with who are obese and also have congestive heart failure, scoliosis, or diaphragmatic paralysis. What is fresh gas flow decoupling valve and what is its role? I think we talked about it in the discussion on machines.
Preventing addition of fresh gas flow to the ventilator
it
delivered
prevents-
tidal volume, sir.
Very good. So it will be only set tidal volume from the machine.
Volume.
Ventilator will be
Delivered.
delivered and fresh gas flow will have no. So fresh gas flow decoupling is a valve located between the fresh gas flow inlet and the ventilator in a circle system breathing circuit. Okay. It prevents fresh gas or oxygen flush from being added to the tidal volume during inspiration by diverting it to the reservoir bag. Thus, fresh gas flow decoupling system ensures delivery of the accurate tidal volume and prevents barotrauma and valleytrauma. Okay. So these are all the roles played by this. So this picture will tell you that this is the location of the decoupling valve, which is in a closed position now. So the ventilator bellows when it is pumping the gas, it is sending it to the patient. And when it is in the open position, the fresh gas flow which is coming is not able to, it is going only to the reservoir, the bellows in the reservoir. So the next breath it will be pumped in. So this is a role that it plays, how it is going to deliver exact flow. What is the disadvantage if you have this decoupling valve in the machine? It is present only in Draeger machines, not in all machines. What is the disadvantage? Why not all machines are including this? So depending upon the relative position, the fresh gas flow decoupling valve may under circumstances mask any massive leaks that may be in the system. Okay, so that is the disadvantage. What are the parts of I mean, what are the ways preset tidal volume is delivered accurately in Draeger machine? So there are three methods by which a Draeger machine can deliver. One is by fresh gas decoupling. It is, I told you, it is present in Draeger. So that is the valve that is currently there. In other machines, they are electronically controlled discontinuous fresh gas supply into the breathing system. And there is a closed loop feedback control to deliver the preset tidal volume. So these are the three methods by which, not in the same machine, but different manufacturers use different technologies. So in the Draeger, it is fresh gas decoupling. Other machines use electronically controlled discontinuous fresh gas supply. And some machines use what is called closed loop feedback control, where any excessive gas will be vented out. Only the set tidal volume will be delivered to the patient. Now you are seeing some scalar or graphics of a ventilator. Can you calculate the static compliance using the information from the scalar shown here? Normally you find these three scalars displayed in most of the ventilators. Okay? One is pressure time, second is volume time, third is flow time scalars. Okay? So how to calculate the static compliance? If you see the pressure, how do you interpret this pressure scalar, pressure time scalar? Is it reaching the baseline?
So plateau pressure and peak pressure.
But is it reaching the baseline or is it above the baseline?
Peak and
So there is a constant peak.
some amount of
So
peak
that's
is
a
there.
gap. So the volume is 400. You can see in the volume, the scalar showing the volume is 400 ml. You can see this. Okay. And the plateau pressure here is between 20 and 30. So this is the plateau pressure. And the positive peak pressure is between 0 and 10. So let us take it as 5. Okay. So this is the plateau pressure 25, peak pressure is 5. And so static compliance is equal to volume returned by plateau. So, plateau pressure 25 minus P5, so 20 is the pressure. And so 400 divided by 20 ml per centimeter of water is the static compliance. Now you have another scalar shown here. This is the scalar on a ventilator providing support to a patient in ICU. What is seen and what action to be taken?
Some obstruction in the tube, sir. That will be suctioning.
In the tube. Now this is one breath which is going up to 35 centimeters of water. This is another breath which is also going to 35. But there is one negative deflection.
Spontaneous.
Very good.
Spontaneous effort.
So spontaneous effort is there, but why it is not going into a normal breath or a full machine breath? What is the sensitivity here? See here, when the line comes to 10, there is a trigger, isn't it? This is a machine trigger, this is a patient trigger. So only at 10 centimeter, machine is triggering a normal breath, whereas patient is able to generate what pressure?
5
Okay.
minus
So
5.
the breath shows that there are both patient triggered and machine initiated breaths are present in this. Okay. Negative deflections on the pressure time scalar are present for both complete breaths. You can see this is the negative deflection from 10 centimeter for both. Whereas the there is a negative deflection between the two that did not result in a ventilator breath. So a close look at the amount of pressure triggered the ventilator is about 10 centimeters. So this is the, as soon as the pressure has dropped to 10, there is a negative deflection going to cause a breath. And the negative deflection in the center of the pressure time scalar demonstrates that the patient could not generate enough negative pressure to trigger a breath. So what you should do? You should reduce the sensitivity. So sensitivity to be reduced to 2 centimeters. So from 10 centimeters, you reduce the sensitivity to 2 centimeters of water. Then machine will support his breath and patient will be getting a full machine breath also. So the main action to be taken is reduce the sensitivity to inspiratory negative deflection. This is spontaneous breath. Okay. What is this?
Flow.
Volume control.
Flow time curve.
Volume control.
Machine control breath. See, if you see the spontaneous respiration, this is not forming a square wave pattern. This is slightly curved. So if you get a classical square wave pattern, this is a machine controlled breath. And what is this?
Auto peak generation.
See, there's a marking here.
Auto peep, sir.
Auto peep, yes. It is air trapping or auto peep.
Expiratory line not reaching.
Expiratory not taking longer time to reach the, not reaching the base. Okay, so and it is also a prolonging. So this is air trapping or auto peep. Now there are two scalars shown with the arrow marks. Can you identify what are all the arrows indicating?
In first graph,
Shadow is
first
the
arrow is it initiation of
What is this arrow? What is this arrow? Only two arrows in this line. First graph. A. This is starting point of inspiration. Going up to this, then it is the starting point of expiration.
Expiration.
So identify the scalar. What do the arrows point? First is that these are pressure time scalars, and in A the rectangular figure indicates pressure target, and triangular curve indicates the volume or flow target. Okay, so flow will always be like this. Pressure will be always like this, and the upper arrow increases the peak inspiratory pressure (PIP), and the lower arrow indicates the peak. Actually, starting point it is above the baseline, so there is a peak here, and this is the PIP or peak inspiratory flow in the upper graph. In the lower, it's a volume controlled breath which is depicted. So here it is a pressure time scalar, and the second one is a volume controlled breath which is depicted. What are the arrows? Again, this will be peak. This will be
pressure. Peak inspiratory pressure.
plateau pressure.
Flat pressure.
Top arrow indicates peak inspiratory. The second one points to plateau pressure. And the bottom one points to peak. Okay. Right.
Tasoscope.
Oh, excellent. Anybody using it? Immediately identified the whole thing. So what is the expansion of Tasoscope?
The Anesthesia Society.
Scope. In Who designed and invented it?
Mangal Dev sir from Mangal sir.
Mangal,
Actually, it's from
I think Mangal
Rajkot.
Dave. His name is Mangal Dave. Okay.
Mangal Dave, yes, sir. Yes,
Gokul Super Speciality Hospital, Rajkot. Very good.
that's
What are the advantages of this?
advantage, sir, is actually
Easily
low
accessible.
cost. It actually costs around 8,000. Like it's actually the prototype is actually basic thing. So it's a Fuji guided technique.
Reduces what is
Technically, what is the biggest advantage? You are talking about
reduces what
economy.
is space.
The economy, it's actually economical.
Economy is a secondary factor, but
Reduces what
more
is
It's
space.
a mouth opening actually to be limited. Limited mouth opening is required for.
it can
this
be
one.
earlier it was
Hyper-extended-
not used for limited mouth opening. Now they have made a design which can be used in limited mouth opening. But more than that, what is the purpose with which he designed the whole thing? If you have read that article, he says why he designed it.
Portable.
Because he was
Reduces
mainly
what is space.
where he was working, Dr. Mangal Dave. What made him design this scope?
Portable.
Portable. All scopes are portable. This is a form of what laryngoscope? VDL.
Sir, video
And
laryngoscope, like hyperangulated.
So you don't have to have any typical positioning.
Position,
Especially
position.
cervical spine injuries, you can just
yes.
like that introduce it and go along the tongue in the middle and then
Yes, sir.
identify the epiglottis and then push the bougie inside and railroad your tube. So there is no need for any extension, jaw thrust, chin lift. Nothing is needed. That is the biggest advantage of that. Okay. So it is a channeled, anatomically angulated video intubation aid with an endoscopic camera, which can be connected to either your mobile phones or even tablets. Ascope has an anatomically angulated metal blade with a fixed 5.5 mm endoscopic camera and a channel to guide bougie. Can be connected to mobile phones and videoscope. And mobile phones are being basic amenity in present age, cuts down the cost, making it more affordable. No separate charging of the battery is also required because mobile phone battery is always there. So this is the method how you use this. So A is the complete set of the scope with the handle, the curvature, everything. So as soon as you introduce the blade in the middle of the tongue, slide it along the middle of the tongue, you will come across the epiglottis. And once you see the epiglottis, you can see the bougie is first threaded into that. After that, you railroad the tube here. So that is how the whole thing is done. Describe phase 2 block. Sorry, all the answers are there. So the question is, what is phase 2 block?
The repeat administration of depolarizing agent like succinylcholine, patient will produce a feature like act like a non-depolarizing agent, causing a fade phenomena. It's actually the succinyl phase block.
Excellent. Okay.
Pseudomonas deficiency.
What is this? Why it becomes like a phase 2 block? I mean, a non-depolarizing block. What is the mechanism exactly? You are
Desensitization of the receptors. Desensitization of the receptors.
No, how does the desensitization occur? What is exactly is happening? Normally, when there is a stimulus coming to the neuromuscular junction, which particular pump is important for excluding the sodium and potassium to back to its normal places?
Sodium, potassium, ATP.
Sodium, potassium, ATP. Okay. So the answer for that, forgot to put the animations here. After sustained depolarization caused by succinylcholine, sodium potassium ATPA pump returns membrane potential close to resting level, but still not enough to respond to stimulation by acetylcholine. Okay. So this is known as phase 2 block. What are the other names for this phase 2 block? Dual block or desensitization block. Okay, it's also the other names for that. So when does dexamethasone produce this? It can be at high doses, not necessary that it can be a repeated or a continuous infusion. even if you intubate a patient with more than 4 milligram per kg instead of the routine 1.5 to 2 mg, then also you are likely to get. And what is the frequency of stimulation used in a single twitch and why? When you try to use the nerve stimulator to find out the strength of single twitch stimulation, the frequency is from 1 hertz, which is 1 stimulation per second, to 0.1 hertz, which is 1 stimulation every 10 seconds. Normally, you prefer 0.1 hertz because this will exhaust the muscle soon and cannot give a correct nature of muscle activity. So, if you use 1 hertz stimulation, it will just show the strength of the contraction, but repeatedly using, you will weaken or make the muscles become tired. Okay. Now, what are the primary ventilator modes for mechanical ventilation? We are going to use a mechanical ventilator. What are the primary modes? I'm not asking the types of ventilation, modes of ventilation.
Volume control, pressure control.
Volume control, pressure control are all triggering methods.
Assisted control.
Modes, you have to say only there are 2 primary modes of mechanical ventilation. One is assist control mode,
Spontaneous.
another is synchronous intermittent mandatory ventilation mode. Okay, so it can be an assist or a totally controlled mode, or it can be a synchronized intermittent mandatory mode. What are the modes of ventilation? This is for patients who are going to be taken over and ventilated. If supposing a patient is breathing spontaneously, then what modes can be used for them? The patient is breathing spontaneously, but you want to augment his breathing.
Pressure support ventilation.
Pressure support.
Continuous pause to
There are different types which include CPAP. First is continuous positive airway pressure support ventilation, and volume support ventilation. Okay? These are the 3 methods which can be employed for a patient who is breathing spontaneously. Which airway? What is airway pressure release ventilation, and what are the advantages and disadvantages and indications for this?
Used in DS patients.
That is indication. First of all, define or explain what is the airway pressure release ventilation. FERV is a mode of ventilation used in a spontaneously breathing patient to recruit collapsed alveoli to improve oxygenation. That is the purpose. And it's a modification of continuous positive airway pressure, where pressure is released for a short time. That is the main difference. In CPAP, it is a constant. Supposing you set 7 centimeters pressure in a CPAP machine, that same 7 centimeters will be present both during inspiration and expiration. That is why it is called constant or continuous positive airway pressure. Whereas if you temporarily, for a brief period, you release that pressure and then re-establish that pressure, that is called airway pressure release ventilation. This brief release helps to eliminate carbon dioxide by spontaneous breath of the patient and prevents the peak expiratory flow returning to 0. It will be always little higher than 0. So the next breath can be easily initiated. Since this mode is pressure dependent, volume delivered depends on lung compliance, airway resistance, and patient's effort. So CO2 elimination is dependent only on patient's own spontaneous respiration in this. The machine will not hyperventilate or try to extract the carbon dioxide. And the indications are acute lung injuries or ARDS or severe atelectasis. Okay, these are all the conditions where it will be useful. So that closes the ASCII based questions also.